Good afternoon, everyone. I'm Matt Craw with Verity Solutions. I will be moderating this webinar today. We're excited to have Josh Free returning to join Verity and co-present on pharmacotherapy clinics and how they can maximize your 340B program. We're also being joined by Scott Milner for the first time. So for those of you that don't know Josh, Josh has 20 years of experience as a healthcare leader, focused on growth, team building, operations, and strategy. Josh has been integral to the success of multiple organizations with leadership positions in retail, long-term care, and hospital and health system environments. Josh is a 340B and pharmacy operations expert with numerous successful strategy implementations as a health system leader and as an independent consultant. Josh's experience includes leadership at one of the largest 340B programs on the West Coast, as well as being a past health system vice president and chief pharmacy officer. Josh received his PharmD from the University of Iowa and an MBA from the University of Colorado at Denver. Scott's a senior consultant with Nelco Advisory. Scott has a diverse background in health system pharmacy operations, including roles in alternate and home infusion divisions. His contributions extend to the oversight of 340B programs, where he's played a crucial role in ensuring compliance and a successful HRSA audits in 2013. Scott's breadth of experience allows him to grasp the complexities faced by different types of hospitals and assist them in standardizing operations despite the varying staffing challenges. I just want to say as a friendly reminder, this is a lunch and learn, maybe an afternoon snack for our friends on the East Coast and lunchtime on the West Coast. We will be sending out your vouchers depending on what you selected when you registered. Any issues, you can feel free to reach out to us at the end. We'll put our contact information. And before we jump into the content of the presentation and pass it over to Josh and Scott, I just want to do a quick Verity commercial for those of you that are new to Verity. So Verity is a full service 340B TPA. We have a extremely high customer retention rate. We are the most awarded TPA by Class Research. We have a 99.9% uptime. We use Amazon Web Services and have an agile development model, which means that we can keep up with the times in 340B and evolve at a very rapid scale. We are also fanatically focused on security. We have a high trust certification, so we are doing everything we can to protect your data and keep the bad guys out. We are truly 340B experts. Our team is composed of pharmacy techs, pharmacists, PEXIS 340B ACEs, nurses, and even former 340B program managers such as myself. We are committed to the 340B community. We're a founding member of the CV 340B group. We're corporate members of NAC, and we're corporate partners for 340B Health. So now that we got our 30-second commercial over, we'll turn that over to Josh and Scott. Exciting content here, and just a reminder, anybody that would like any questions that you want to discuss at the end of today's presentation, feel free to put them in the chat pane there, and we'll be answering those questions at the end. Josh, it's all yours.
Yeah, thanks, Matt. I'm really happy to be here. I'm really glad to be here with Scott. Maybe some of you have heard me talk about this concept before or seen it on my LinkedIn, but what we're really going to be talking about today is, as you should already know, is pharmacotherapy clinics plus in-house pharmacy. And as many of you know, without the in-house pharmacy, you don't have a place to qualify your prescriptions as much these days because of those contract pharmacy restrictions. So these two things really work well together. So we're really talking about pharmacy as a strategic asset. And the old school mentality on pharmacy can sometimes be that it's just another cost center and a very expensive one at that. And I like to shift thinking and present pharmacy as a value-added clinical partner and a revenue-generating strategic asset. And unfortunately, it's not always viewed that way. So when we look at 340B strategy, I think it's really important to note that it's more than just having a few analysts oversee compliance. I know some entities are doing pretty good just to have a little bit of FTE dedicated to the 340B program. I think the strategy takes a bit more than that. And the value of the program and the reach of the program, particularly in complex health system environments, is such that it can influence your formulary decisions, clinical programs, and where your services are actually located. And so to fully optimize your 340B strategy, we've got to look at all of those things and just know that it can change decisions that you might make. When we talk about implementing strategy, though, getting buy-in is so important. Your relationships with your C-suite and with other leaders in your organization is critical to getting buy-in for pharmacy strategy. That may sound obvious, but I think we all know there's a lot of barriers to doing that. So, I mean, Scott, you were in a chief role not long ago here. What are your thoughts on this topic in terms of working with your peers and C-suite?
So I will admit, the first time as a young leader, I struggled with resistance to how fast I thought things should go. And I wish we lived in a world where pharmacists didn't also have to do the patient clinical work and some of this other dynamic and sell while we should be at the table. But the reality is, I think everyone has a little bit of that. So I call it healthy tension. And so when you approach these people, it's good to learn what motivates them, what things they're feeling pressure on. And so when you articulate some of the things that we go over today about how this is a financial win, how this addresses the patient pain points, and then also how our pharmacists, there's a lot of rewarding topics ahead here. I think it's helpful for all of those strategies.
Absolutely. And the other comment that I have up here, and I've just always been a very numbers-focused, finance-focused leader. It's just part of my personal style, I guess. And I always think about getting buy-in, particularly from the finance team and the CFO, by demonstrating some hard numbers, as opposed to when I think of soft numbers, I think about things that are really hypothetical, programs that are derived at decreasing length of stay, for example. Not that decreasing length of stay can't be real, but it's very easy to poke holes in that analysis. Theoretical labor cost savings, things like that. Those analysis can just get beat up to where people don't believe it. One of the cool things about 340B strategy is you can put some hard numbers to that. You can say, here's all the stuff we don't qualify today. Here's what it would be worth if we did. Here's what it would be worth if we only qualified 10% of it, and sometimes even that can be a really substantial number. So anyway, just my take on getting buy-in is do your analysis and put forward analysis that's hard to poke holes in. We'll keep moving here. So the overall strategy we're talking about here is one, qualify more patients for 340B, and two, capture those prescriptions at your own pharmacy. Now, realistically, a lot of entities are still capturing things at contract pharmacy. That's fine. We know that that's gotten harder and harder over the last few years. We're not really going to dive into that topic too much, but just know our focus here is that if you can fill those prescriptions at your own pharmacy, that's going to be the optimal situation. In doing so, you have a great opportunity to improve quality, decrease errors, increase patient engagement, support your physicians, and capture some of the financial benefit. All right, so pharmacotherapy clinics. So what am I actually talking about here? If this is a new term for you, or if you might know it by another name, people might call it MTM clinic. I don't love that name for it, but I call it pharmacotherapy. So what I'm talking about is referral to a clinical pharmacist for complex med regimen management. By referral in the health system space, in the hospital provider-based space, what I really mean is a physician order, and that's much like ordering any other service from an auxiliary provider, which under Medicare rules, that's what pharmacists are, auxiliary provider. Physicians can order that service, and there's lots of examples of that. So regardless of what your state says about pharmacist provider status, nationally and for Medicare, we don't have that. We can argue that we should. I think we should, but at least for now, we're auxiliary providers. But that doesn't hold you back necessarily on seeing patients in this way, which we'll get to. So ordinarily, we're using a collaborative drug therapy management agreement, or a CPA, if you prefer that acronym. not going to go into a bunch of detail on the CDTM, but many of you, of course, will already know there's lots of models for how that works. Your state may have requirements. Your organization may have standards on that. This, in my opinion, should be a very comprehensive clinical agreement, normally authorized by a medical director and approved by a P&T committee. I know sometimes people get stuck on these if you haven't done a lot of them. If that's something NALCO Advisory can definitely help you with if you need support there. A little more about the pharmacotherapy clinic. And so really we're using it as a mechanism to meet 340B patient definition, AKA establishing responsibility of care for the patient. And so that referral into, in the health system world, where you have to have a clinical encounter and show revenues and expenses on your Medicare cost report for that department to be eligible. This visit with the pharmacotherapy pharmacist, which we're going to bill for and have documentation of, that establishes that responsibility of care. And Scott, I know people ask questions about this sometimes, like, does that really make them your patient? But you know, this is a kind of tried and true method at this point, right? What are your thoughts?
Yeah, you know, and I think a lot of times when I hear pharmacotherapy, when I first heard about it, I didn't know what to liken it to. And I just want to point out, like, the anticoagulation clinic model is kind of a similar discussion as like what it looks like from billing and a holistic, you know, picture of the revenue and how you bring that into the pro formas that you use. But yeah, when we look at, you know, from an auditing standpoint, we're trying to make sure that you have documented clinical visits and you're maintaining the record of the patient and you are taking care of them. We've seen both HRSA auditors and others look up those notes from both pharmacists and other, you know, clinical providers. But in all reality, this is a real easy way to solidify the type of care you provide and also extend the type of providers that you have in your entity or health system.
I've definitely had clients that struggled with the patient definition part and weren't sure that this passed muster. I think it clearly does. It's a billable encounter. Again, not really, even in my opinion, not even really controversial. It's clearly an encounter in the eligible department of covered entity. If you're not a hospital covered entity, your needs from a compliance standpoint are slightly different. So I know I'm focusing a bit on the hospital side. We'll talk more about community health centers and others. Now this strategy can be useful in those environments as well. So there's a couple things you might do with this. So sometimes these are used as a way to meet patient definition for patients who are otherwise served at a non-eligible location, or in the hospital world, a non-provider-based location, maybe a clinic that's part of the medical group. Might be if you're a multi-covered entity system and maybe one of your entities is subject to the orphan drug exclusion, but another is not. You might strategically locate this service at a DISH hospital that's not subject to the orphan exclusion. And then you're able to qualify that patient under a more advantageous covered entity. I think sometimes people think that sounds controversial. To me, it's really not. Hospitals decide all the time where to place certain services based on the economics. So not particularly controversial in my opinion. And also you could use this for patients who don't even use the covered entity otherwise. Referral from an outside provider is acceptable in this environment. Not everyone chooses to do that, though. There are compliance considerations behind that to think about. The Medicare Benefit Policy Manual speaks directly to this topic. So it can be done, though not everyone does it. And I think that's a good place to just note that you cannot, it should not compromise on compliance, whether it's 340B compliance, Medicare billing type compliance. All of those sorts of things are super important, of course, to do this the right way and to minimize your compliance risk. And again, I'll pull Scott in again here. I think we've both experienced navigating compliance directors and chief legal officers and folks like that this stuff is really important. Those folks have an important job, and a lot of the time when I'm working on a pharmacotherapy project, that's a lot of the project, is navigating those concerns with those particular people. Scott,
yeah.
What's your
it dovetails on that buy-in conversation, because if everyone's familiar with this program, is well aware that it's good to have this kind of revenue. It supports a lot of operations. It's very vital in how we provide care, in our communities where we are at. But really, it's always handy when you can expand the the footprint and make sure that compliance is lockstep with that. And so these are all things that pass muster if this is a new conversation for you. This isn't something that's hokey or some sort of loophole, like Josh, you've been talking about. Like, this is from the CMS manuals. We're seeing these clinics across big and small systems or covered entity types across the country that gets audited routinely year in, year out, both from HRSA and an independent auditor. So that compliant picture is really important to understand, that we're talking about things that are well documented, well founded, and can be replicated.
So, and those concerns are among the reasons why these clinics maybe aren't as common as I think they ought to be. There's a lot of systems out there that could go after this strategy, use clinical pharmacists at top of license, achieve some really great clinical outcomes by using the pharmacists. And I think those compliance concerns are among the reasons why it doesn't happen. I'm going to keep moving here. There's a lot of content. We're going to move pretty fast here. We're trying to leave some time for questions at the end, but just a little more about this pharmacotherapy clinic strategy. And one of the reasons why I'm such a big advocate for this strategy is it's so effective, but also it checks a lot of boxes in terms of all the positives that you can have. So a clinical quality, and I'll give you some examples of that a little bit further down the presentation here. But at the same time, there's a great deal of patient satisfaction. Maybe not every patient loves this, but most that I've been around, most of the time patients really enjoy having another healthcare expert to ask questions, someone that can spend a little more time with them than what maybe their physician is usually often able to. And the other piece of that is there's the financial benefit, and you got all three of these things. And if you only have two out of the three, you have maybe some things that aren't as optimal. But when you've got all three, I think it's a recipe for a sustainable engagement with the patient, where you've got quality, the economics work, the patient is satisfied. And I didn't add a fourth circle because it makes the Venn diagram too complicated, but I would add physician satisfaction. That in my experience, physicians, when they get used to this model, become to really rely on it and really like it. That doesn't mean they always start there. That's one of the barriers to implementation. Sometimes if the physicians don't quite get it, or there are misconceptions maybe about cost, quality, what pharmacists can do, you're stealing my patient, things like that. Like, those are all things that can be navigated. But in my experience, the physicians usually really get behind this if it's properly, thoughtfully implemented. All right, so what are you going to use the clinic for? So I kind of break this up into primary care conditions and specialty conditions. So when I think of primary care, I think of diabetes. Obviously, there's other stuff, but diabetes drives so many adverse outcomes. And as we all know, there's a bunch of expensive drugs in that category that are driving a lot of cost. The GLPs, you can't talk about pharmacy without talking about GLPs these days. It's the hottest thing going. So that would be certainly, I think diabetes is just such a good example here, because it's a complex disease state, lots of drug options, lots of suboptimal care. And frequently, especially primary care physicians can be overwhelmed with all the choices amongst all the other things that they take care of besides diabetes. So great opportunity for a pharmacist to optimize and to standardize care. Within primary care, tons of other areas we could look at. It's a great opportunity for the pharmacist to be an extender of sorts for the physician, particularly if we're talking, and again, I'll refer to diabetes here. If we're talking about complex drug regimens in the diabetes space, and if the physicians aren't getting the results they want, there can be maybe a desire to refer to endocrinology. If the issue really is the drugs, I think the pharmacist is the better resource, not to knock on our endocrinologists. Plenty of great endocrinologists there, but a clinical pharmacist, particularly residency trained primary care clinical pharmacist that focuses on diabetes, is going to be, in my opinion, the right clinician for optimizing the drug regimen. So,
and I just want to add, I once was a director at a critical access facility. We didn't have an endocrinologist in our city, and so this is, we had a few primary care physicians that were very savvy, And once we earned their trust, our pharmacists were able to be more of a peer in that space and extend the kind of care that they were providing. So
Absolutely.
very well said.
And, this probably goes without saying, but, we've got a larger patient base for primary care, but generally a little lower value in terms of the 340B economics as compared to specialty. When you setting aside all the clinical benefits and the patient satisfiers, all those good things that I think should be the driving reasons for this, focusing on the economics for just a moment, just roughly stated here, your brand name, non-specialty primary care type drugs, you see a value after drug cost, after TPA fees of in the range of $300 to $600 per month, pretty commonly. There's some are more, some are less. 300 to 600, pretty good benchmark. So that really means for every 100 patients that you can fill just one prescription 12 times a year, if you capture that at your in-house pharmacy, that's a value, just simple math here, $360,000 to $720,000 per year per 100 patients, if they're getting all 12 refills a year, which we know sometimes they don't, right? That really undershoots the value because these patients that are ideal candidates for this service are on more than one drug in most cases, right? And you've got more than 100 patients. Even a small system has more than 100. So you can do the math. If we were trying to scope your particular fact pattern, I'd be looking for how many prescriptions did we write for Ozempic last year, or an insulin, or whatever disease we're looking at, and we can kind of figure out what the potential value is. Shifting over to specialty, all the biologics for sure, especially the rheumatology drugs and the Humiras and Stellaras of the world. We're seeing tons of Dupixent right now for a million different indications. We could certainly talk about oncology. In some ways, I think oncology is a little bit of its own animal for different reasons that we don't have time to dive into here. But all of those sort of specialty drugs have a ton of value in this sort of model. And just focusing on rheumatology for a moment, general population health statistics tell us, about 0.5% to 1% of the population have a rheumatological condition. And so there's not a small number of patients out there that could be on a Humira or a Humira biosim or one of the similar drugs for, if not for a rheumatological condition, for a dermatological condition, gastroenterology type disease. So there's quite a few of these patients out there. This model works nicely for those sorts of diseases. Of course, your specialty drugs have a little higher value in many cases. I mean, even the biosimilars still are priced higher than your non-specialty brands in many cases. However, when we talk about specialty, now we're in a class of drugs that is more susceptible to payer restrictions in terms of where you can fill that prescription at, depending on your state, right? There's a few states that have some really strong any willing provider laws that are opening this up a bit, but we can expect commercial patients are going to be very restricted on where they can fill these drugs. You are much more likely to encounter orphan drug exclusion. So if you are one of the Affordable Care Act entities, critical access hospitals, rural referral centers, soul community, et cetera, this can affect your economics, and the contract pharmacy restrictions are disproportionately within the specialty space. So really, I'm looking at top conditions where you see this a volume of patients and where you see this model work: rheumatology, gastroenterology, dermatology. Still a lot of Hep C, and a great way to use pharmacists. Neurology, particularly some of the migraine meds, have a good value and work really well in this model. And again, I'll say oncology with the little caveat that sometimes that's has other considerations. In terms of value, just again, ballparking a lot of these drugs, $1,000 to $5,000 per prescription per month, sometimes much more, depending on what specialty drug we're talking about. But if we just use that range of $1,000 to $5,000, which it's still a big range, 100 patients, 12 times a year, $1.2 million to $6 million per year in value after drug cost. So certainly behooves you to look for these specialty drugs. And if you are prescribing them within your system and need a way to qualify them, this would be high on my list. We're going to transition over to billing. I know we're going fast. Again, we'll leave time for questions at the end. This is probably where I spend the most time when implementing, outside of compliance, so this ties into compliance, when implementing one of these clinics. So hospital covered entities. First of all, yes, you need to bill for this. You deserve to get paid for this service, first of all. But secondly, you run into all kinds of inducement, Stark law type concerns if you're providing a free service. Now, that doesn't mean that there's not room for charity care within this model. You can do that subject to your organization's policies. Every hospital kind of treats that a little bit different. There are ways to write off that cost in some cases. It's a complex topic that we're not going to dive into here, all those aspects, but we should be billing for this. And among the reasons is you have to make your department eligible. If you create a department that this is the only service you're offering in that department, you've got to show revenues and expenses on your cost report. So if you're not billing, you're not going to show any revenues. So, a few considerations here. We're talking about in the hospital world, we're talking about incident to billing. So again, pharmacists are not providers under Medicare. They are auxiliary staff. The pharmacist operates incident to the provider's order. It's billed on a UB. The referring provider is the NPI number that the payer actually sees on the bill. So there's a bunch of detail here into how you do this, but it's should be pretty straightforward to your billing folks at your health system. 42 CFR and Chapter 6 of the Medicare Benefit Policy Manual speak to this. This is important to get this right, and an area where people get stuck. For your non-hospital settings, now we're talking about billing on a 1500. So that's a professional fee. The professional fee means the NPI of the professional who rendered the service is on the bill. If that's a pharmacist, some payers aren't going to pay for that. However, in your community health centers and other environments, the compliance on the 340B side is a little bit different, where we're not necessarily needing to show revenue and expense on a cost report for that clinic to be eligible. So there's a little more to it than that, but let me just say the nuance in the non-hospital setting is a little bit different. You could also look at some other options besides billing a 99211 CPT code, which is kind of your standard office visit on the professional fee side. You could look at MTM codes. That's not appropriate in every state, but some states have what we call expanded MTM, where this is pretty common. You cannot use those MTM codes in the provider-based setting, by the way, not reimbursable by Medicare. And there's some other codes that might be appropriate. So a few options there. I think I said this already. The billing and the compliance is the number one reason these projects fail to launch, where folks get stuck on Stark law, charity care implications, the rules of the provider-based settings, physician supervision, provider status, all these things cause people to just get stuck. And I've seen it happen where we've got a good opportunity to implement this kind of service and it doesn't happen because we can't get to a place of agreement on these nuanced compliance topics. So all of these things can be managed. Many hospitals have survived audits unscathed. So again, number one reason these projects fail. If you're stuck here, come talk to me. Would love to be able to help you implement. All right, with that, we're going to shift over to the capture those prescriptions at your own pharmacy discussion in just a second, but I want to give you a couple real world examples of some pharmacotherapy clinics that I've worked on and some of the results that happened there. High level, for any implementation, I'll just say this is a significantly complex project. Scott, have you ever tried to do a complex project in a health system world without project management? It's a mess, right? So
yeah,
you need resources.
And I think the key thing here is making sure this is also part of that buy-in dynamic. I've had everything line up, but then someone in the billing office saying, "Hey, pharmacists can't bill for that. You're not a provider, or you can't. Here's the rules as we read them." And so I think also this is part of that conversation as you're proposing this to maybe do the elbow grease outside of a meeting with everyone at the table to make sure you answer questions and concerns and make sure that you're prepared to answer and speak to those hurdles so that it's not a roadblock.
Absolutely. Yeah, so I would just say when I advise on one of these projects, I call it technical project management. We're there like guiding through those all the steps of the process. If the system has a project management office and wants to also assign a project manager to work with me, we do that too. That's fine. In fact, that's really helpful. But I really believe in good project management. It can sound like overkill and feel rigid sometimes, but having a charter defining who the decision makers are, who the escalation points are, all the goals, I think that's all important stuff for complex projects. Executive sponsor is really important to have someone to help get us unstuck. If we do have, the technical person in whatever department is like, wait a minute, we don't do it that way. Like you've got to have these things in place.
Yeah, I think I made a mistake early in my leadership career where I had a project manager trying to support it, and I kept thinking, I think I can do this without him. I can set up meetings, and I think what you're trying to say is it's more than that, and making sure that there's not like a last second snag that holds everything up after months of work and proposals. And so some of that project management is the due diligence at the beginning, and making sure that that executive sponsor from beginning to end is behind you every step of the way.
Absolutely. Absolutely. I'll dive into some more examples here, or a little more of a real world example. I mean, but here's my non-exhaustive list of all the barriers, all the excuses I've heard on why people think they can't do this strategy. I'm not going to read them off to you, but this isn't even all of them. Right. So just know that these challenges can be overcome. But again, all the different questions and doubts people might throw at this project, all the more reason to have an executive level sponsor and project management and the buy-in of the leaders over those key things that you need: billing, IS, physician leadership, all of that. All right. Let's talk about diabetes again. Going back to diabetes, I love this model for this disease. And as Wilford Brimley, I put this in because Scott wanted it. I don't know. It's meant to be. It's meant to be mildly humorous.
I'm going to jump in. That is perfect. We love Wilford Brimley, the diabetes. It's great.
In my mind, this was really funny. I don't know if it's translating that way, but all right. Wilford Brimley says, let's work on diabetes. So I set out with a small health system to focus on the diabetes population because this particular group had quality, we're not meeting the CMS quality metrics, large number of diabetes patients within their system, a couple thousand, as I recall. And just overall, we're not getting those folks to goal. So a lot of detail to how that project came about. But once we got that approval, we set two goals, that we were going to improve the rate of patients with an A1C less than 9. We wanted to improve that by 10%. So A1C of 9 is the CMS quality measure. And then diabetes patients generally should be on a statin, another quality measure. We wanted to improve that from our baseline by 10%. So in order to do that, we closely followed the first 100 patients just to check our progress as this clinic rolled out. Backstory for this group: the physicians were pretty resistant, and we had executive buy-in to launch this thing, but we were struggling to get the physicians to refer at first. And so what kind of ended up happening, which ended up being a blessing in disguise, is the physicians were willing to refer early on were only the patients that they had kind of thrown their hands up in the air with. Can't get them to be adherent. They're out of control in terms of their labs. And so the average A1C at referral was 12 to 14, which is not good. I think we had quite a few patients that were 16, 17. So these patients needed help. And largely, with diabetes population, it's a drug therapy question. The percent of patients on a statin, we had a tougher time measuring that. So we didn't have a baseline on that. Here's what happened. The statin metric is not as exciting. We exceeded our goal of 10% improvement in 1 year. The pharmacists found this to be pretty tough. Actually, the patients that aren't on a statin often have a lot of reasons why they don't want to be on a statin. And so what we did improve this metric, which was good. A1C, however, was a lot more interesting. So we following those first 100 patients, we remeasured their A1C at 3 months. Normally, when they were referred, we already knew their A1C. If they hadn't had one recently, the pharmacist would order another A1C lab. I believe was pretty close to this clinic, so it was pretty convenient for the pharmacist under the collaborative practice agreement to order the A1C and send it down to the lab. What we found was at 3 months, which we didn't even expect really much movement at 3 months. That's the soonest you would retake an A1C. We found 95% of our patients reduced their A1C by some amount. 70% got to quality goal of 9 or less, and 50% got all the way to therapeutic goal of 7 to 8, depending on the patient, within those first 3 months. So this was we thought was pretty phenomenal results. I don't think any of us, I mean, we said we wanted to improve 10% in a year, and here at 3 months, we were hitting way better results than that with probably the most difficult patients. So this was kind of beyond our wildest dreams. And once the message got out, how successful working with the pharmacist, optimizing the meds in the pharmacotherapy clinic was for these diabetes patients, we had very few issues with physicians referring from that point on. They just couldn't argue with it anymore. It was a really resistant group, but with those kind of results, leadership messaged it back to the physicians that if your diabetes patient is not at goal and you're not referring them, when we've got this kind of results with this tool available, you have to refer that patient. You're harming your patient if you don't send them, right? After a year with this group, the pharmacotherapy clinic had 2,000 impaneled patients. Last I checked, this was a few years ago, last I checked, they're up to 7 or 8 pharmacists at this point. Continues to grow. The quality metrics and the trend of A1C improvement held constant. Physician engagement grew, and the model expanded out to other diseases. Net margin ended up being about $700 per patient per month because these patients are on multiple meds for those prescriptions captured at the in-house pharmacy. So good results there too. And I'll just talk briefly about a similar clinic structured around rheumatology. This was a group that had a medical group-based practice, 340B non-qualifying clinic, pretty large rheumatology clinic, and they had kind of been stuck on compliance of this for a few years. For construction, like real estate reasons, it was a clinic that was not feasible to turn it into a hospital department itself. So the pharmacotherapy referral model was the best way to go. They'd been, like I said, they'd been stuck for a little while. We were able to navigate their compliance concerns, update the 340B policy, got the clinic open and staffed within 6 months. And interesting thing happened, had a little exodus of some physicians, and we were able to use the clinical pharmacist to kind of bridge, to kind of maintain continuity of care, to keep the existing patients taken care of in that clinic. I stuck with them for about 6 months post go live, and in that first 6 months, 600 referrals of patients with various rheumatological diagnoses. They had 400 patient encounters in that 6 months, qualified 250 prescriptions, and that was a $1.1 million net value after TPA fees and drug costs within the first 6 months. So I thought that was a great start. Scaled, this group probably has a $20 million a year opportunity, but they got off to a pretty great start right out of the gate. Now, this group has some advantages that maybe not everyone has. You see the 250 qualified prescriptions out of 600 referrals. That's a pretty high rate. Part of that is because they have their own specialty pharmacy and they operate their own health plan. So good conditions to do this with. So those are a couple examples of real world results. So let's transition over though and talk a bit more about prescription capture, because again, it's the pharmacotherapy, all the clinical benefits are great, regardless of where the prescription is filled, but better at your own pharmacy, and the finances, of course, are better. So for that, I'm going to switch over to Scott here, and he's going to lead the rest.
Yeah, thanks, Josh, and for everyone watching, I may switch my camera off if I have any bandwidth issues. A few times it was holding me up, so if that happens, I'm going to try to make sure the audio is clean. And Josh, you mentioned this, and I just want to underscore that you just cited some examples from the revenue of the 340B contribution. We mentioned about the necessity to bill for the services, not from just the ability to have that as a revenue component, but also to be part of the qualification of the department, right? Having expenses revenue. So I just want to emphasize that that's important. So I love this picture because, fall of 2019, when manufacturer restrictions were hitting, I think I was a little bit taken back and a little dismayed and wondered, boy, 340B has been such a wealth of a benefit to the communities that I worked at. But how do we navigate that and remain compliant? So I felt like it had always existed in trying to make sure you increase your capture, again, financial benefit and compliance hand in hand. But the contract pharmacy opportunity is fantastic, but there's always some barriers potentially that have been there in place, but now it's a little more complex. So with more and more manufacturer restrictions hitting the market ever since the first ones in 2019, the ESP dynamic is one that had a lot of discussion. I know I had a lot of heartburn, mostly around, are we willing to submit data? What does that mean? Is it difficult? What are we giving up or getting? And then also some advocates for alternative distribution models, as the ship to bill to is kind of emerged. They're complex. It's not really easy. I think that if you have a good 340B committee, you can have the discussions. But also I want to point out the in-house pharmacy expansion is a real easy way to make sure things are clean, who's benefiting, and how that is leveraged in your hospital or health system model. So go ahead, next slide. I love this because I've worked at places where we didn't have an outpatient strategy at all. We didn't have a department or a team. Or sometimes we have one, but it's maybe not optimized. And so for those of you that mightn't be in either of those buckets, I hope that this is helpful. It'll feel a little bit like a checklist. So for me, when I tried to stand up an entire outpatient department, my pharmacy team, phenomenal as they were inpatient centric. Maybe we filled in on the side at an outpatient pharmacy. I was a little bit nervous to compete with some of the local independent pharmacies who were not only good members of our community, but sometimes they were my friends. Our kids played on the same sport teams, and I didn't want to feed someone else to starve some of them. But as we've seen, some of our good partners in this space with the manufacturer restrictions, so there comes an opportunity, whether that's purchasing that business that might be struggling, they've been reliant on the partnership, or even maybe there's enough opportunity that you can both exist. There's also space constraints. No, I've never worked at a hospital that had too much space, at least once they opened for about 30 days. It's really hard. I heard a friend share on a podcast recently. I made the same mistake. There's those wonderful gift shops at the front of your hospital. Hey, maybe we could put a pharmacy there. Fun fact, don't. Those volunteers not only are phenomenal in what they provide, but it can burn you a little bit if you try to take over that. So whether it's a ministry-based entity that you have, that maybe some sisters that run those, or the volunteers or the pink ladies at the hospital I worked at one point, you have to find somewhere that's both available and functional, and trying to find a balance there. And again, if you don't have people on your team that can run an outpatient or a specialty or any of those programs, can you recruit someone in addition to the pharmacotherapy? That's a real question. And I found that when I have recruited any of my guys or ladies I went to pharmacy school with to come over to the health system side and the outpatient, they love the ability to see a more complete picture of our patients, especially where we share an EMR on both sides of the house. So next slide. anytime you're going to do this, I remember years ago reading, I think it was the University of Utah was one of the first times I heard about it, but definitely a lot of groups have said, hey, we're going to take our entity-owned retail or outpatient pharmacy, and we're going to put them into a different business division so that we can jump the GPO prohibition. And that sounded romantic to me because, boy, howdy, getting that whack percentage every month sometimes is a little bit painful. But if you're going to look at those opportunities, be very familiar with the FAQs that address this, and make sure that if you do, how do you have that report? Because there's a benefit if you're entity owned to not have those manufacturer restrictions. There's also a potential if you have a designated contract pharmacy that you might have to forego those savings there. And are you going to be able to displace that value or not? And also, again, if you have a multiple entity strategy, how do you make sure that the prescriptions are qualifying across the hub and spokes that might exist, especially if your hospitals are really close together? Sometimes it can get complicated. And I've already mentioned the ESP trade-off. I think a lot of the heartburn settled down with ESP, but it's still sometimes caused a pause. Next few things are a little bit checkbox. So wholesaler, you're going to utilize that primary vendor that you use. I found in my outpatient space, there's sometimes more necessity to bring in a secondary wholesaler or distributor, especially with like vials and some of the supplies that aren't even 340B. Sometimes you can negotiate some better pricing for those materials. Class of trade, if that's a new conversation to you, an open versus closed door, there's some of those conversations that you need to at least check the box that you reviewed it and that your team understands it, especially those executives that are going to be helping you drive this. Are you going to utilize a TPA? Hopefully you have a really good TPA, especially if you're on this call today. Are you going to be a clean site? Are there other things that you're going to do with your purchasing strategies and how those things are going to be moving? The Medicaid carve-in or out, it feels like years ago your state kind of helped maybe drive some of that to some degree. They would indicate a preference, or more and more I'm seeing entities kind of participate in the discussion at the state level. And if you are going to carve in, how those pass on to the state, what are you going to do with the out-of-state Medicaid? And then again, we've already mentioned inducement, Stark, and other things. I loved when I lived in a small town. One of my executives made the statement that we want people to come here not because we're local, but because we're the best choice for them, right? Shop local because you can beat them at the service. In fact, a fellow coworker of mine once said, we want to be that white glove service, so we are the easiest choice to make. And so we aren't requiring them to come through, but keep that in mind. Optimization, as Josh alluded to, the employer-sponsored health plans. It's really good when you can have some synergy. I love the patient assistance. I think probably the most rewarding aspect of my 340B side of my career has been establishing those programs, especially if it's an in-house pharmacy. You just have a little more control over how you explore that and how you execute. And utilizing 340B to help a patient is probably the most rewarding things of my career, to be very honest. Specialty, or specialty light, I know that that's a hot buzzword. You might even establish a specialty pharmacy as part of this conversation if you have enough volume, making sure that accreditation, if it's needed, or if you have resistance from the payer contracts as well. And also, I always make the statement that years ago I had the opportunity to contract with the local teachers union, and that was phenomenal. I think we both won on that side of the conversation, but they were able to make sure that they had the right pricing that kept their teaching, covered entity or covered lives, well funded into the future. We were able to provide a great service as well. Next slide. A little bit more, but I feel like we've had a little bit of a checklist. So obviously licensing, distributor decisions, PSAO, if you're unfamiliar with what that is, it's impossible to negotiate payer contracts individually. I can only imagine how difficult that would be, especially if you're new to the space. It's going to be hard. A lot of your distributors have a PSAO, and are you going to utilize that? I have never been equipped to perform some sort of RFP in that space. But if you want to review that or take that, just take it, ad hoc as it is, making sure what that means and how you get access to actually process the claims. And then also there's Board of Pharmacy requirements. Some do, some don't. Making sure you have that flow of patients in that space once you determine what it is. We've already talked about project management, and everyone's very understanding of the difficulties in getting FTEs and resourcing. I just want to pause. I have in my career been asked to just do this on top of other things. And unfortunately, I've done it very poorly. And so I think one of the clear winners in this strategy is be very clear about the revenue potential and be comfortable with what you can deliver, and so that you resource it appropriately. You know, if you ask for a car, you might not get everything today, but don't settle on just a wheelbarrow kind of thing. So make sure you get something that you can build and develop, and be comfortable with iterations and growth, but also don't undersell yourself in making sure you have the essentials in place to start. Next slide.
Scott, if I can go back to, you mentioned PSAOs a little bit here, and just got me thinking. I mean, if you aren't operating your own pharmacy today, and you're looking at some of the daunting processes of getting one off the ground, payer contracting is one of the obviously important parts. Your hospital payer contracting team may not have any experience with this side. It's obviously different than the medical side. A member of my team actually just very recently did a side-by-side comparison of most of the major PSAOs. Pretty interesting findings. So that's something that we're very, very recently, very directly experienced with, is looking at the options there.
Yeah, I think if you go into the space, it's something that you might not tackle day one, but it's probably worth revisiting a year in once you've been able to, you know, cement this strategy in your team.
And that takes us to the end here. So, you know, hopefully we've got time for questions here. So would love to take some questions if our moderators can help us with that. And again, I'll just say, you know, hope the enthusiasm behind this strategy comes through. It is truly my favorite thing to work on, especially as a pharmacist myself, to see pharmacists be able to practice, top a license, and just have really incredible outcomes and financially sustainable outcomes in this kind of model. It's really, really fun to work on. So,
yeah, no, Josh and Scott, thanks again. Very informative. We do have some questions in the chat pane. I didn't know if you both wanted to maybe share your contact info on the screen. I don't know if you've got that handy, just while we're going through the Q&A, just in case anybody wants to follow up afterwards. Some questions around, are we going live in the recording? So just want to make sure the answer to that is yes, we can do that afterwards, no problem. The first question comes around my favorite topic, around billing. Always seems to be a challenge with these types of builds, and you know, personally, I've struggled to get the finance and the rev cycle departments and the health system I came from to really understand what we're trying to do here. The question is mainly around telemedicine. So we hear about these types of care delivery models being done through telehealth and pharmacotherapy clinics. And because it needs to be a billable encounter in a 340B eligible location, and the ability to build telehealth for hospital-based locations is going away at the end of the year with the COVID PHE ending. How can you continue to do telehealth and video visits? And do you just not bill for the virtual visits, or is it best to just write off the charge?
yeah, that's a good question. So I would describe this as a risk tolerance decision. So there are ways to do some telehealth in this model. The note about public health emergency flexibilities around virtual visits, that's 100% true. The problem you have in the health system world side of this is what you're billing for is a facility fee, and Medicare says you can't bill the facility fee if you didn't use the facility, right? And so that's really what's happening. But that doesn't mean that you cannot see those patients. It means you can't bill for it. So long as you are doing, and again, it's a little more nuanced than this, so I'll just say that the stance some entities take is that so long as we aren't exclusively reliant on telehealth, and that we are having inpatient encounters, and maybe in policy, maybe we want to require an inpatient encounter every so often, once a year, something like that, right? Then that's a position a lot of folks take. So there is some ability to do some telehealth. I would caution you if you were relying exclusively on telehealth, particularly in the provider-based environment.
And as a small rural referral center or hospital, what do you both think is a good first step to start the process of scoping out a pharmacotherapy clinic?
So your RRCs are subject to the orphan drug exclusion. So I would start with a detailed analysis of what do we prescribe today. Are those drugs orphans is going to be part of the calculus here. So we got to make sure you correctly account for whether you get 340B pricing on some of those or not. But I mean, I tend to do an analysis of what's everything we've prescribed in the last year. What's everything we've referred out in the last year to some other specialist, right? And just to try to gather, like, what do we have? What's our base of patients that we could refer through this clinic? And then, there's some other detail I would look for there too. Who are the payers? Is it all Medicaid? Does my state allow me to do anything with Medicaid in the 340B program? If you're in California, this is really hard right now, as it's become exclusively fee-for-service benefit. That means you give the benefit to the state of California on the pharmacy benefit. So I would start with that kind of analysis to estimate what do we have and what's it worth if we capture it.
And I would just add, I tried doing this prior to some of the ability to get this type of information. Like when we had everything printed, I had a tough time seeing exactly everything that was being written for and prescribed and where those were going. And so a lot of EMRs today actually provide some of that data, and it's a little bit less intimidating to obtain. So that analysis is a little easier, I feel, than about 10 years ago. It felt really difficult to really cement the opportunity.
And I'm going to throw up, since you asked, I'll toss up on screen Scott and my email addresses here. So just in case folks want to follow
up. And as far as location of the pharmacist goes, have either of you seen a situation where the clinical pharmacist is embedded in a non-hospital based clinic and the referrals are sent out to the covered entity?
Let me make sure I understand. And I thought I saw this pop up on the chat as well. Like, I think maybe was the question also, like, could that pharmacist be in an outpatient pharmacy themselves? So just a few general comments here. So non-hospital covered entities, maybe there's some additional flexible models you could think about, but if you're a hospital covered entity, you are relying on rendering that clinical service in an eligible department. So if the pharmacist isn't located in an eligible department, it just really doesn't work. Telehealth excluded, setting that aside. Folks have asked me before, well, could we have that pharmacist in an outpatient pharmacy? And you really can't, because your outpatient retail pharmacy is not an eligible department, which is kind of counterintuitive, right? So when we talk about eligible departments that are on an eligible line of the MCR, the pharmacy isn't one of them. So yeah, you really need to have this housed in a 340B eligible department. And so for your provider-based settings, that means following the provider-based rules, billing a facility fee. Clinic appears on line 90 of the cost report, or 50 through 118 are also options. So yeah, it doesn't really work to park them out like at a clinic out in the medical group.
Josh, I think with COVID, there's a lot of things we hoped would stay, right? It wouldn't end. There's a lot of things that we demonstrated, like telehealth, like how easy it was, not just from a patient and provider adoption, but it makes time spent like a lot more streamlined. Is there an opportunity, like while you have this clinic, that it's maybe not on the cost report, to treat that as if it's like a referral, like a documented from an eligible location? So I think I say that there's some things to consider and think about and how you could do it, but I want to be clear, I've never seen anyone successfully try to utilize an outpatient pharmacy as a qualifying visit, and I think that's pretty clear. That makes me cringe.
You know, I mean, how risk averse are you, right? You know, I mean, I'm not going to say there's not things that maybe are defensible, but I wouldn't recommend that route.
Yeah.
Yeah, I think the right way to do it really is to get that pharmacist practicing out of an eligible location, and it takes some time to make that clinic eligible. So, as an interim strategy, could you park the pharmacist in a different eligible clinic that's already on the cost report? There are sometimes that can work. Um, Not always, depends. Everybody's fact pattern is a little bit different, and that's part of the analysis here on should we do this? How much is it worth? And then how do we go about it? Right? If you have a place that you can stick the pharmacist right now, and you got an exam room that's not being fully utilized, and say, well, you know, one of my clients had a nurse-run coag clinic. It was eligible. It was in the hospital. Coag is not really that different than it's. I think coag is pharmacotherapy, right? So we parked the pharmacist in there and just updated our Epic build to account for what the pharmacist needed to do their job, and we used that right out of the gate until their permanent location was constructed. So there's a lot of ways you can go about getting it off the ground. It just everybody's different.
All right, guys, we are at the top of the hour and out of time. Appreciate the dialogue today and the great presentation. Again, for the folks on the line, anybody that has questions, Josh and Scott are tremendous resources on this. So highly encourage you all to reach out to them. And thank you all again for attending today.
Thank you.
Thanks everyone, and thanks Matt and Verity for hosting and for having us.
Of course, happy to have you. Thank you.